eastern section of the country.
Hailing from Saco and Biddeford, Maine. All right,
All
so
right, so
so we had
so
we have a patient
we have
that
our paper.
go ahead and kind of share the
Yeah,
backstory.
I mean, I'd like to, if I can, just even pull up like his age, but we'll call him DK, Mr. K. Um, so he came to our office about a year ago and had complained about TMD stuff, but at that time it didn't seem like it was major. He had been in for a couple of periodic exams over the course of a year. I think by the third one, he was kind of like, I've tried physical therapy. I've tried all these things. I feel my TMD symptoms, my TMJ issues are out of control, and I would like for you guys to look at it. I've been told you guys, do that. And so we sort of listened to him and said, let's get you in. He's 38 years old. He's a healthy guy other than the fact that he has this history of cardiomyopathy that was idiopathic, but his cardiologists and physicians have given him a clean bill of health. So there's not like major concern there. He does have some like mild periodontal. I'm just looking through his chart. He has some really localized periodontal issue with like his lower left molar. He had previously been, I think, at Gentle Dental or another dental office and had fillings done. He feels like his bite's off. He feels like his jaw is tight. He feels like his left PMJ is like almost like it hinges weird, especially compared to the right one. He feels like he deals with chronic pain, chronic TMJ and myofascial pain. He talked about how his sleep is just really poor. He said maybe at best I get 4 hours of sleep. I feel like crap when I wake up. I feel stressed all the time. I have a stressful job. I've got a kid. So we talked about just like, although yes, we want to do an evaluation of the TMD, I think we should start with doing a sleep consult. So we brought him in on Saturday, March 1st with Ray, and we did our traditional sleep consult, and we used the pharyngometer along with like the questionnaire and basically just a history and a sleep hygiene sort of history to determine whether or not this is a patient at risk for obstructive sleep apnea. He doesn't fit the standard stop thing, like neck circumference is whatever below 17 centimeters. He's normal height and weight, not obese. He says he's tired on that, but I think basically when Ray did the Epworth sleepy scale or whatever you want to call that, he got like a 2. Yeah, Epworth sleepiness scale. And from what we were talking about, it's not until you reached, I don't know, 10 or whatever. I feel like he got like a score of a 3. It's a subjective test, right? I mean, it's not
Sure.
a end all be all. Yeah, even the pharyngometer, as little as I know about it, from Ray's perspective, low risk for sleep apnea, relatively good volume of airway, good volume of nasal cavity. That was a definite. I could kind of read that because he was in the like above the 50th percentile. It's hard to say because I know there's a bell curve there that it reads. So he's definitely above the 50th percentile, maybe somewhere even in the 70th or whatever in terms of nasal cavity and space. The sort of like pharynx and the oropharyngeal and retropharyngeal area or whatever, I don't think that does it on a bell curve, or it doesn't show you it really. But yeah, but I mean, from Ray's perspective, it still appears like he's got good volume. There was like one space in the most posterior area of the pharynx, which is where he seems very narrow. He has a very, very narrow vertically, not horizontally, where the pharyngeal walls seem to be very kind of close together, almost like the wider he opens, like the closer they get, but not large tonsils. Although he does report a history of strep throat, which he's had multiple times in his life and maybe somehow related to this cardiomyopathy issue. but he doesn't appear to have large tonsils. He just has a very narrow upper and lower arch, although his occlusion is not like in crossbite, but they are certainly, his whole figure is very like tall and thin. And so the pharyngeal walls are very kind of tall and thin. And that's the only area where the volume dips, and the collapsibility is like maybe 60%. And Ray ran 2 tests. So it's like the first one, he's like, I don't know if that was a good one. And the collapsibility was like 25%. And then he did a second test and felt like the collapsibility was 60%. He felt like that test seemed more reliable.
Yeah.
So that's where it was kind of like, from Ray's perspective and everything he sees, it seems low risk if we're just looking at it from like a purely objective standpoint.
Right.
But, it could just be, this guy's got TMD. He's got a stressful life. It's a stressful job. I think his sleep hygiene is out of whack. He definitely appreciates a lot of the like taking care of your body and eating well and stuff, and he like definitely speaks to that, like, oh, I like the Mediterranean diet, and I like to exercise, and I like these things. And when we talked about sleep hygiene, he's like, I understand that. I'm certainly like open. And I think it's just like, if he were to deal with his sleep hygiene, right? So everything he does from that kind of evening time right before bed, I mean, that might just be it for him. Like, it might not be that he's obstructing and he's having apneic events. He might just really not be setting himself up well for sleep. And then he's just not in a great place to go to sleep. So he's just in like, poor sleep, pain, chronic pain, inflammation, TMD. I mean, it's just runaway train at that point.
Yeah. Let me ask a few questions. First of all, beautiful recap. I think the command that you had in summarizing the case exemplifies where you're at in understanding this stuff, and rather impressive. So well done. Dolichofacial would be a term that you could have used to describe the patient without describing all of that, versus brachycephalic. If I was to ask you, give me one word which describes what the pharyngometer measures, what is that word?
Volume. Like,
that's the answer.
I think it measures,
that's the answer most people will give, but the correct answer is
collapsibility.
You got it.
Yeah.
I mean, it's giving you the volume when it's at maximum collapsibility.
So you can do the volume. Yeah.
And I think that's an important distinction. And just, I could hear you kind of alluding to the fact that we can measure volume on a CAT scan, but it doesn't really give us any information. I say it doesn't give us any information. It doesn't tell us what the risk profile is for sleep apnea, because you can have a large airway that's highly collapsible. That patient has OSA. Yeah, I know you know the concept. There was another aspect to this. The psychological component. Dr. Bryant went over this in I won't say in detail, but he covered the kind of the psychology component of TMD at the lecture this past weekend. And he doesn't believe that TMD is connected to what he calls psychosocial. I don't think patients who, how can I say this? I think it's fuel to the fire, but it's not the igniter to the fire.
Yeah.
Agreed. It can turn up the volume knob on the symptoms. No doubt, we've all seen patients that have the history of, I once had jaw pain, but that's when my life was stressful, and it got better once I retired. That's a common thing I hear up here in Bar Harbor. One of the concepts, as we start to kind of unpack how to look at these cases, I think a full command over intracapsular versus muscle, and you use the term MPD, myofascial pain disorder, very accurately, so that suggests that you understand the difference. But when we say TMD and we start pointing at the joint versus the muscles, I think it's important to know that those two things can often be very separate and distinct entities, and how we approach them and whether or not sleep is related is very much dependent upon us kind of having a clear picture on that. So one of the things that I gleaned from the lecture with Dr. Bryant this past weekend was if the joint isn't seated in its fully seated condylar position, or FSCP, which can be thought of as centric relation, but it's not always centric relation. But in the, how about this, the optimal position of the condyle within the fossa, whatever that is.
Mm-hmm.
If we're not there, then the muscles that hold the jaw need to hold it in a position that is unnatural for them, and that can create myofascial pain disorder, simply from the fact that the muscles are being asked to almost sit in a, what's that term used? There's a term, like if you push on a wall, static, myostatic.
Like
isometric.
Yeah.
Yeah, so an isometric position, basically.
That's unnatural for them. Yeah. And awkward in a way that they're sometimes like uneven.
Correct. So the way he treats these cases, he doesn't really treat myofascial pain disorder. He gets the condyles to seat, and his theory, which comes from Mark Piper's work, is that if the condyles are seated, the muscles are happy and the muscles get better. So
interesting.
That was my big takeaway from his lecture. That's really why it's very simple for what he does. He's creating a flat plane orthotic on the lower that only contacts in the posterior, and I have a couple slides we'll take a look at together to
that'd be good.
Kind of discuss different appliances. But his goal is to create an appliance that seats the condyles, and the muscles in turn become happy. The joint heals, and if the joint is healed, the muscles are improved, then the mandible can return back to its malocclusion position. And that's kind of an interesting thought. If we seat the condyles and the muscles become happy, wouldn't we want to equilibrate the teeth or orthodontically move the teeth to create an occlusal scheme that matches that condylar position? And it's interesting, and if I ask Harry that question, I'm not sure what his answer would, well, I have an idea what his answer would be. It's not as clear as yes or no, or it's not a black and white answer. But I think his answer would be something to the following. Once you heal the joint, the muscles are happy. The muscles are fine going back to that position because now the condyles are healed. Well, why were they inflamed in the first place? We might think they were inflamed because the jaw was in a bad spot, when in reality, it could have been from some trauma or some other external factor that caused the condyles in the joint itself to become inflamed. Therefore, the muscles became affected because it was trying to stabilize the mandible.
Yep, that makes sense. I mean,
versus the condyles when the joint itself is unhappy, it's maybe not so much because of the occlusion. Therefore, when you fix the joint, everything,
you reset the system,
everything goes away,
and then it can return back to its what seems like the occlusion isn't, because from our perspective, I understand how a malocclusion puts the jaw in incorrect position, but I kind of could see that perspective of like, once things heal, the adaptability of a healed joint and healed muscles is fine to go back. I wonder if it then returns, and if it does, then is it not trauma based? Is it malocclusion based? Or
well, here's what's interesting. I went back through my notes from Dr. Walker's lecture.
Yes,
and she said the same thing. Now she's creating an orthotic which is based upon kinesiology concepts, but in reality they're kind of the same thing. I don't want to say that, but they're kind of approaching the problem from a similar angle. I had asked her, I was like, what do you do when you're done? And she said, she's an orthodontist. So I was like, do you do ortho on all your patients? She said, I do ortho on very few patients. And I was like, how is that even possible? She's like, well, the system is healed. And I remember being like, That doesn't make any sense. But I've thought back to her comment,
Interesting.
and I followed up with her and I talked to her about this, and I actually have a recording of a Zoom call that her and I did, and I'll have to revisit that. But Carrie kind of echoed that same sentiment, which is once the joint is healed, then the muscles act properly. So if we think of that, let's call that a primary joint problem with a secondary muscle problem.
Mm-hmm.
That's when a flat plane orthotic does the trick.
Yes.
Because really all we're doing is we're taking away, we're giving the joint and the condyle freedom to go where it wants to go.
Mm-hmm.
And then what he does over a period of time is he adjusts the orthotic to facilitate the seating of the condyle even further.
Okay.
So think of it as that door in the door frame analogy. He's creating a new door frame, and then he's shaving it down to allow the door to swing closed appropriately.
But he does it, so he actually does it over time because of inflammation, because if you just get that thing seated in the beginning, it's probably going to seat against inflamed tissue. Is that why? You don't want to overload an inflamed, irritated system, so you have to like walk it in over time?
Yeah.
I mean, that's what I'm thinking. I don't know.
Yeah, I don't think you'd be wrong in thinking that. I think it's probably more complex. It probably has more to do with how the muscles are allowing it to seat.
Okay.
In addition to the inflammation. That's a good question. That's something we could definitely follow up on.
Yeah. So like so basically like, he gets them into position, but I assume he's like almost decreasing the vertical of the splint in a way. Is that
not changing the vertical, changing the trajectory?
Okay.
So if you picture that jaw being on a hinge,
mm-hmm.
the closer it gets to that pure rotation, the
mm-hmm.
more you're going to have changes in the splint as that starts to happen.
Okay.
So think of it as when the condyle is not in its fully seated position, you have translation and rotation. How does that show up on the splint? And then as you seat it more and get to more pure rotation, the trajectory of the jaw and how the splint contacts the opposing teeth will also change.
So he must see real changes in like, oh, it's been a couple of weeks, whatever. We go and do our tapping. It's like, wow, the bite's actually way different. And just bring it right back to the same concept of posterior occlusion. So he has no anterior occlusion.
Yeah, and I kind of challenged him a little bit on that. I was like, if you
it's just good to know.
Let's have that conversation when we talk about the different orthotics.
It's just interesting. All right, I think that makes more sense than that. Yeah, it's basically like he's going to follow up with them. He'll see a change, so you keep bringing it back to the center. For him, it's posterior contacts, and then things are changing. He keeps adjusting until they keep coming back to that same spot.
Yep,
that makes sense.
And he's really just looking for what he said. He called it group function. I'm not sure he was.
Yeah, he did talk about that
group function. Canine guidance / group function. I'd be curious to get a stronger sense of exactly what he's looking for. I got the sense that he's not very precise on the occlusal concepts when it comes to the adjusting of the splint. Basically, he's looking for kind of equal contacts left to right, and then a relatively balanced lateral intrusive movement, which he calls group function, whether it's true group function or canine guidance or a combination of the two. I don't think I really got that out of him. The adjusting of the splint is something that I feel like I have a pretty strong command on, and yeah.
Okay, that's good.
I guess my point is I don't think it requires the fanciness of kind of the complexity that I often try to think about occlusion when it comes to TMD therapy. Um, he's putting an orthotic in, and that piece of plastic is treating the joint. If you think about it, how is it that oral surgeons have been treating the joint using a piece of plastic, but they know nothing about occlusion? There's something about a piece of plastic that does a lot. Now, can we maximize the outcome by understanding how the occlusal scheme should be on the orthotic? Yeah.
Probably, yeah.
But it's not the bulk of the therapy. It's more of the finished carpentry aspect of building the house, and not so much the stick frame itself.
Yeah, and there's also going to be the outliers, or the ends of the spectrum, who need maybe that detail.
Sure.
And there's going to be the people in the middle who just truly need some posterior contacts with some balanced lateral intrusive movement.
Yeah.
And it sounds like, that may be not dumbing it down, but like that, that it's like not rocket science when it comes down to it. You just follow a couple simple concepts and
all he's doing is bringing the patient back, tap, 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 grind.
It's also possible he subconsciously is doing something that he what's the competency? Unconsciously competent, right? It just like, I just know I do this.
Right.
And sort of like, we don't even know, because he doesn't really, he's just like, I just do this because I know, but he can't tell us he knows. So I hate to go down that road.
No, I think that's true with any expert. There's a degree of that unconscious competency that's kind of baked into their abilities to do what they do. To kind of recap, we'll call it the primary joint approach.
Okay.
So from this point forward, we'll call it the Piper approach, which is Kerry Brand approach, but he learned from Piper. So what he's doing is he's creating a lower orthotic posterior only to give the condyle its freedom to go into a fully seated condylar position, with the expectation that the muscles are going to respond favorably.
Okay.
Whether or not they had myofascial pain disorder or not, or some sort of muscle reaction. Subsequently, he then may or may not decide to idealize the occlusion in that fully seated condylar position. The jury's still out whether or not that's important. I would love to revisit the video with Dr. Walker to see what her thoughts were on that. But what I'll say is most patients are treated to an acceptable point simply by having the orthotic seat the condyles and have the muscles respond well as a result of that. So we'll call that the primary joint. Then we'll call the primary muscle approach, which is myofascial pain disorder as the primary problem. That, I would say, is manifested by two different things. One is occlusion, and that's what Dawson was very big on, was the teeth don't come together appropriately, therefore the muscles respond negatively. That's what the neuromuscular people look at. That's what the T-scan people look at. In other words, how the teeth come together drives the potential imbalance in the muscles, whether or not the joint is a problem or not. Those are the patients we tend to make interior deprogrammers.
Okay.
All right, so that's kind of coming full circle. Let me share my screen. I was starting to put together a little flow chart to help us.
I mean, the basic version of the anterior deprogrammer, like the NTI, is that just a really bad version of it? I mean, I don't think that many people use the NTI, but
can you see my screen?
Yes.
All right. Let's see if I can minimize this. All right, so
there it is.
That's the NTI there. The NTI is just another anterior deprogrammer. It's I would say a lab fabricated, although it might be. Yeah, we'll call it a lab fabricated Lucia jig. So
yes.
Lucia jig would be another term for this. Essentially, what we're doing here is we're taking advantage of the fact that when we bite in our front teeth, there's an inhibitory reflex that turns off our elevator muscles, or inhibits, mitigates, obtuns. I think obtund would probably be the right word. Turns down the volume of the contraction of the elevator muscles. And the reason we have that is because our anterior teeth are designed for incising food. They're not meant to be under the pressure that our back teeth receive when we're masticating food.
Mm-hmm.
So when we bite out back, the proprioceptors that live around the posterior teeth facilitate strong contraction of the elevator muscles. And on the contrary, when we bite in the front, the proprioceptors that are in the front say, yeah, you don't want to do that. So we have less force. So there's kind of, I think there's a 8-to-1 relationship, like, let me see if I say this right. The force out back here is 8 times the force in the front, based upon two things. One, the turning down of muscle activity, but also the physical lever effect. Like a nutcracker, you'd put the nut right here based upon the physics of the force versus
distance from the hinge.
Distance from the hinge.
Yeah.
So there's kind of like a physical component, but also a neuromuscular response component to it. So by putting this here, we in essence turn off the elevator muscles, which in occlusal muscle myofascial pain disorder. When I say occlusal muscle, I'm saying the same thing as myofascial pain disorder.
Yeah.
Just different schools of thought. What we're doing is we're telling the proprioceptors to turn off the elevator muscles, which are the muscles that are often the ones in spasm, based upon some sort of issue, whether it's entrapment in the front or it's occlusal prematurities in the back that are causing the jaw to have to shift to bring the teeth together. So it's a malocclusion, and the muscles are unhappy with it. That's myofascial pain disorder in a nutshell.
Okay.
So the NTI appliance was developed, and there were several things that kind of gave it a bad name. One is you could swallow it. I don't know if that ever happened, but that was kind of a risk factor that was propagated from the anti-NTI contingent. Two, it was thought that we would intrude anterior teeth or cause like an anterior open bite. And
or a super eruption of the posterior and still do the same thing.
Exactly. Yeah. So to take a quick step aside, Spear talks about a study that was done by an orthodontist where he measured how much time would have to be required for super eruption to happen passively. And it's something on the order of like 12 or more hours. And what that means is if you're wearing an NTI only at nighttime when you go to bed, that's 8 hours. That's not enough time for super eruption or intrusion to occur.
Okay.
Like you need a certain amount of force over a period of time for tooth movement to occur. So how is it that patients with the NTI appliances were showing up with anterior open bites? Any thoughts?
I mean, it could be condylar position changes.
Yeah.
I mean, then I'm thinking that like like now the condyle's seating in a different position, and they're like, and like everything is seating trajectory wise, like posterior touches first, and now they're like, whoa,
you hit the nail on the head, bud.
Yeah, teeth haven't moved, but the muscles are happy and the joints seated in a different position. Well, that's the point of the lucha jig, is to seat the condyle.
Right. So, and that's kind of the funny thing about it is when that happens, you've actually achieved a more optimal outcome. Now the question is, what do you do with that?
Okay, I see. So now they're in centric relation, but they're not an MIP, and then now they're seeing the discrepancy between the two.
Right.
Why don't my teeth come together? Well, because your joint's finally seated. Well, I want my teeth to come together, and that's where that's where they would say, okay, well, it's occlusal equilibration, orthodontic movement, or prosthetically changing your teeth.
Yep.
What is a different version? So not an NTI. What does an anterior programmer look like from like a full arch orthotic, or well, can they be full? I don't know.
This would be one right here. So an anterior ramp.
Oh, okay. Yep.
This is kind of like a DIY. This patient's in protrusion, but my bet is this was an Essex appliance. I've made these quite often. My residency, we made these. It's an Essex appliance with just a little acrylic ramp. So what's nice about these, although this one only goes here, the Essex covers all of the teeth. So if there was some concern about the risk of over eruption,
sure, that
you're not worried about this.
Yeah.
So it's in MIP or centric occlusion, which would mean the condyle seated, so it would mean centric relation, but we'll just call it MIP. Whatever the maximum, or not the maximum, the natural closure position is, all the teeth touch, and then the moment they slide left, right, and forward, they're in. So this replicates a natural occlusal scheme. Is really that's a good way to describe it.
I see. So it's like really not exaggerating, but idealizing the mutually protected occlusion and canine guidance. Like,
yep.
So they can come together and touch everything, but as soon as the jaw moves, which it has freedom to move because it's not locked in position, as soon as it moves, it's mutually protected occlusion and canine guidance, the whole 9, and that's the deprogramming effect of it, because now they're going to like slide onto their anteriors and.
Correct.
Okay.
Yep. This photo is taken from Leanne Brady. She's, I believe, the new director at the Dawson Academy, or Pankey, one of the two. But this photo here is from a highly well-renowned, comprehensive dentist, I guess would be a way to describe it. So, to kind of boil it down, I would say this is the appliance you use for myofascial pain disorder. And
it's typically a maxillary appliance when we're doing this, or does it depend?
You could do either. I would do lower.
Yeah. So, and I'm just seeing in maybe the last couple months, if we're going to make an orthotic or an occlusal guard for a patient with a deep overbite, somebody at some point explained, well, first that the upper teeth tend to be a flatter occlusal plane for some reason, and I couldn't even tell you why they said, but that the upper teeth tend to be a flatter occlusal plane, so it's much easier to like idealize the lower with an orthotic or an appliance, because you're then going to hit against something flat, where like the lower, sometimes those lower teeth are hidden, but they're very, the curvus B is very exaggerated. I'm just seeing people with class 2 bites where, it's almost like the lower teeth, there's an exaggerated curvus B. They have a bit of like maybe super eruption of their lower anteriors, that making a lower seems easier, way easier to adjust and like get them easier into. Otherwise you make an upper and the thing is just like, it's bulbous in the premolars, and then it gets like shallower. I don't know.
Yeah, I think all of the high points that you articulated are very relevant. In a nutshell, lower's better when we can.
Sure.
Depending upon the occlusal scheme. One reason why I don't like uppers, just to use this photo, this is a Coist deprogrammer, but just to use this photo to make the point, an upper appliance has a thickness in this zone right here, which for an airway patient will further perpetuate the constricted space of the tongue.
Yes.
So lower appliances for airway patients. Well, for an airway patient, we're probably going to make a combination, upper and lower, to hold the jaw forward. But it's good to not interfere with the space where the tongue goes by creating an upper appliance when you can create a lower appliance which doesn't have that effect.
Okay.
And one of the super interesting things, this is something that I don't know when I fully kind of had this aha moment, but I'd be interested to see what your thoughts are. If you think about it, where does your tongue live when you're talking? It's kind of low. So you would think, but really its rest position is in the palate.
Yeah,
which is up high. So, especially when we're breathing when we're sleeping and we're nasal breathing at night, the tongue being postured up into the palate is the ideal position.
Mm-hmm.
So, but if you look at a patient and you're doing an exam, their tongue is living down low, which is not where it spends most of its time. So, you know what I'm saying? It's interesting when we look at patients, the tongue is next to the lower arch. So
Yes.
one might conclude that's where it lives. In reality,
And then that makes sense. I see what you're saying.
It really lives up high.
And so because of that, we're like, oh, we don't want to put an appliance on the lower because like the tongue's right there, like how big that thing is. But yeah, I see what you're saying. When we think about where it actually lives in its most comfortable state, yeah.
So this is the Kois deprogrammer. So this is an upper with a little anterior discluding ramp right here, and it has kind of like a Hawley retainer wire that kind of wraps around. I think the reason why Kois came up with this is because it maintains the natural occlusion so that you can adjust the teeth as the patient wears the appliance. Like, how do you, as a dentist, how do you equilibrate somebody with the guard in, but also get the teeth to come together appropriately? I don't know, and I think that's why Kois came up with this, which is he can equilibrate people because the only plastic that's contacting the opposing teeth is right here.
Okay.
This is a Lucia jig attached to a full plane appliance that the patient lives with. And maybe he brings the patient back every, 4 to 6 weeks and tap, tap, tap. The patient's been deprogrammed because they've been wearing this, and they're now contacting the teeth in a more seated condylar position because the elevator muscles are turned off, and then he'll equilibrate, improving the patient's occlusion, and just continue with that, using the patient's normal anatomy as the adjustment medium versus the the plastic. It's actually super brilliant. I've never done one. I have a couple friends that are Kois faculty members. I will see if I can get them on a phone call and just kind of see what they do with the appliance. But
that concept would be quite interesting. It's like a occlusal equilibration over time.
Correct.
Like instead of just doing it on a model and saying, all right, we're just going to go from point A to point Z. It's like potentially, if this is what you're saying, it's like it's A, then it's C, then it's F. It's like you just kind of like are walking it in.
Right. All right, let's take a look at
so that's just a CR.
This was the beginning of a flow chart to try to exemplify in a very simple way how this goes. TMD splints. I put over the counter here because I think having that conversation is worthwhile, but we'll have it after. Okay. Intracapsular, extracapsular, how we diagnose these two is something that we could dive into. But just to talk about the different orthotics, intracapsular issues, a flat plane orthotic, a posterior only or a Gelb appliance, a Kois anterior repositioner. This is different than the Kois anterior deprogrammer. Let's look at that in a moment. And then a mandibular advancement device, although used for airway, could be considered treatment for an intracapsular condition because you're pulling the condyle away from the inflammation rather than...
Which is typically in the retrodiscal. Is that why?
Correct. Retrodiscal, or just the entire compartment where the inflammation occurs is exacerbated when the condyle is seated versus it being pulled down and forward.
Okay. Yeah.
So like if you picture there being a pillow behind the condyle, we can call it the retrodiscal space, but it's more than that. The medial pole, the superior compartment, it's really the whole thing. It's the back end, it's the butt end of the condyle, and where it meets up to the fossa is potential space to have inflammation. Pulling it down and away with a mandibular advancement device can be considered a therapy for an intracapsular condition. Okay. I think there used to be an appliance called a pivot appliance. which was meant to kind of do the same thing. This really isn't used anymore, but I think understanding how this worked further outlines and paints the picture of what we're trying to do.
Mm-hmm.
As opposed to this, the extracapsular, we'll call that the occlusal muscle or the myelofascial pain disorder patient. This is the patient that really Dawson was treating through equilibrations. And the anterior deprogrammer is the primary device. The Cois anterior deprogrammer. Anterior disclusion device, Lucia jig. Quick bite. We have those in the office.
Yeah, I was gonna say, do you feel like a quick splint is the white, that white thing that we can reline with Regisil?
Yep.
The quick splint, is that relatively an anterior deprogrammer? It goes maybe premolar to premolar.
Yep.
You know?
It's a quick NTI.
Okay. Yep.
Primarily, it's more used for diagnosis and treatment of acute conditions.
Yes, and that's where I've been okay being, is
sure.
like, I'm happy to help manage acute, and I have had maybe 6 cases over the past couple months, so I have come up with a protocol, and at some point I'll be happy to share it with you, and it needs revision for sure. It's my own.
Yeah.
I took from multiple people, but I have my sort of acute TMD protocol, which I've created.
Beautiful. Yeah, anytime you put protocols together, there's so much value that comes out of that. Just the process of making it is very helpful. And if you make it and it's of high value, then it's transported to other people too. But just the act of making it is super helpful.
Yeah, I kind of forgot that. I guess I forgot that we should just look at it one day.
Yeah.
One of these sessions.
Definitely.
And then that whole idea of like acute management versus this, which is like the chronic, like definitive management. Looking at those two.
Yep. The diagnosis part of like how to end up in these two arenas is something we could focus on next time. I think would be a good use of time.
Oh, I see you put aqualizer. I still don't really because it's too posterior. Do you feel like it's a deprogrammer? It says it on if you look at the instructions or indications, I believe it's termed a deprogrammer. But it uses, posterior contact. Oh, so there's the quick splint. I see it in one of the pictures.
I think I can answer your question if I can find the picture that I'm looking for.
But I do know Kerry Bryan sort of approves of the use of an aqualizer as like an acute or an interim management perspective.
Depending on the.
Well, I guess like you're saying, what is the etiology?
Yeah, if it's a muscle thing, sure. There it is, right there. So think of the aqualizer as achieving the same thing. So occlusal muscle issues comes from a lot of the time posterior tooth contacts that are eliciting a elevator muscle overactivation.
Mm-hmm.
This and all of the other appliances disglue the back teeth.
Okay.
That's what the aqualizer does too.
Yes, and it does. It gives you
it's just a very
literal space. Yeah.
Yeah. And it also, I think there's something about the left to right balance, the fact that you have the gels in that closed system that gives the muscles maximum comfort.
Okay.
There we go. All right, so posterior contact, posterior interference. I don't know why they put that there. They should give that a different color. This is used because of this. So
Yeah.
when posterior teeth come together unnaturally, elevator, the masseter fires, the medial pterygoid fires, the superior belly of the lateral pterygoid, and the three bands of the temporalis. Those are all elevator muscles, and they respond because the proprioceptors around these teeth are programmed in the peripheral nervous system to have these fire. It thinks that this is food. Bite harder. You know, that's why, I don't know if you've ever chewed anything soft and there's something hard in it. Have you ever done that?
Oh, yeah. Yeah.
Do you notice how startling of an experience it is?
Yes. Yeah.
That's because the brain was thinking that it can fire based upon the softness of the food that it first encountered, and all of a sudden it encounters something hard and it just doesn't know what to do. So it just kind of like freaks out.
Yeah.
So by creating the anterior deprogrammer, whatever it is, how about this? Don't think of the anterior deprogrammer as doing anything special other than separating this.
Yeah.
I mean, that's a simplified comment, but...
Sure. No, I mean, it makes sense.
One of the... another very helpful example or take-home lesson that this photo shows, the inferior belly of the lateral pterygoid is the only protrusive muscle. It's the only purely protrusive muscle. So this band right here, when all of these elevator muscles are firing, this is the only muscle that's going to hold the jaw in a position that allows the teeth to close.
Okay.
I know you get it, but let me state it another way because it's that important. The condyle, when it's not in centric relation, because the teeth come together anteriorly, so call that a CRCO shift. You know, essentially where the teeth come together has an anterior component to the condyle. The lateral pterygoid is the muscle that pulls that condyle forward to get the teeth to come together. But if you have all of these elevator muscles firing, this muscle has to work a lot harder to bring the jaw into that position, and over time that muscle becomes fatigued, and that's the muscle that really kind of, a weak lateral pterygoid throws off the whole system. And you know, if it's in spasm, whether or not you can palpate or not is a question.
So that's why that conversation came up, though. I see now. Yeah. And why that muscle is so affected. So in this picture, they're just showing this deprogrammer is turning off the lateral pterygoid. Is that what they're saying? Is that, or as those are firing, it's not, it gives it its negative sign, but.
Yeah, I think that's a little bit misleading. Basically what it's saying is when you have a prematurity in the posterior, that's not firing until the teeth come together.
Okay.
How about, now that I look at it, this gets turned off when you put the anterior deprogrammer there.
Which makes, yeah, I mean, when we talked about the spastic nature of that.
Right. Yeah, this photo is the most important photo in Dawson's textbook. And like understanding it is kind of the crux of everything. I think this is like a modified photo where they put something there.
Yeah, I mean, is that supposed to be the anterior deprogrammer?
Yeah. So that is used to treat that. So I think the original photo doesn't have that there. It's it's posterior interference contact, which causes the elevator muscles to fire.
Gotcha.
And then this muscle has to fight it. So maybe this is actually turned on in the absence of an anterior deprogrammer. And it's turned on so much because it's fighting so many other muscles. I'm going to have to revisit the text to get some more clarity on that.
So, at some point it's, we have these two avenues for treatment. We have the appropriate treatment. So there's 2 diagnoses, and then there's appropriate treatment for each diagnosis. How do we make the diagnosis? Is it just like Terry Bryan said, like an MRI will give you a lot of information about, is it really a healthy joint? If it's really a healthy joint, then
yeah, good question.
Yeah, so basically the original fork in the road from TMD splints, like how do we get to?
Yeah, let's dive into that as its own session. But let me give you my 10,000-foot view answer. 80% of myofascial or TMD is extracapsular.
Okay.
Or myofascial pain disorder.
So the majority of what we're treating, and that's what my understanding has been all along. But
yeah, I think to Carrie's point, like if you treat this and you don't necessarily look at the joint, because you can have this, but it's a joint problem.
Yeah.
Let's table that part of it, but let's just say they're 2 separate and distinct conditions. How do you diagnose one versus the other? Load testing would be one.
Oh yes, okay.
So have the patient bite down on a cotton roll in between their front teeth, and then have them try to bring their back teeth together. We'll load the condyle into the fossa because you have a cotton roll in the front. I say cotton roll, I'd probably use a leaf gauge.
Okay.
And what you're doing is you're trying to seat the condyle, and if they have pain when they clench under that condition, that would be suggestive.
We're going to assume an intracapsular problem.
In addition, the CAT scan, if we see condylar changes, the head of the condyle has to be a certain surface area or volume. You can see osteophytic changes or radiolucencies in the head of the condyle, bird beaking. All of those would be suggestive of intracapsular conditions.
Okay.
Whereas the myofascial pain patient, this is the trigger point patient.
Mm-hmm.
So I had a patient today up here in Bar Harbor. Went to the endodontist twice for pain in back teeth. They didn't find anything. Talked to her for 10 minutes. I mean, I knew what the end of the story was before even looking at her. I just palpated her masseter, and she jumped. It was like, she's like, you hit it. What tooth was it? And I was like, I was palpating your masseter. And she's like, but it hurts in my tooth. And so I pulled up the trigger point.
The referred pain.
Yeah.
Yes, that diagram. I shared that with the patient recently, and how truly they've shown that the pain in muscles can be referred to your teeth.
Yeah. One of the
misdiagnosis really can happen. I mean,
yeah, and I feel like as we start to really become a name within the community, the endodontist referrals, I think, are probably going to be pretty powerful. So if they don't see odontogenic origins, they might say, well, yeah, I need you to go see my friends over at Acadia, or whatever name we choose. Mm-hmm. But one of the things that she said that really, before I even looked at her, not confirmed, but was strengthening the potential that this was a myofascial pain patient. She said sometimes it's on the top and sometimes it's on the bottom. So her tight muscle band went from here to here, origin to insertion, all the way up and down. So one could say that when it's down low, it refers to the lower teeth. When it's up a little higher, it refers to the upper teeth. 100% pain patient due to occlusal muscle issues. And she had several other occlusal hints, recession, wear facets. She had no pain when I palpated her jaw joint. So I had her open wide, and I kind of pressed in this area, no pain. Then I load tested her, no pain. So this is a patient I'm going to treat using an anterior deprogrammer. So one of these.
Cool.
Yeah.
Exciting.
Yeah. The last bit here, over-the-counter guards, the reason why they're not good is because they're not permissive. They don't allow the mandible to kind of go where it wants. They're Boylan bites, so the patient bites into place, and it basically indexes the mandible into a locked position.
Yeah.
Added, you have that compressibility, which to the proprioceptors in the teeth that activate the elevator muscles it's food. So it actually can encourage muscle activity. So the only time I'll ever recommend an over-the-counter splint, if I can't do one of these for some reason, if the patient's out of state, what have you, maybe. But what I'd say is, when they put it in, if it gets worse, don't put it back in. If it gets better, keep wearing it till I can see you. But know that this will not be the final definitive appliance.
Yeah.
Really, we should never do these, unless it was special circumstances. Yeah. Even for bruxing patients. Now, it does protect the teeth, so from a attrition perspective, yes, it's better. But if you encourage elevator muscle activity, are you actually creating a new problem, potentially?
Mm-hmm.
Yeah. Cool. All right, man. Well, that was a good hour. Any thoughts, questions, contributions?
No. I think I want to dive into I think I want to at least present the acute management. Somehow that I never even thought of bringing that up, but it's so relevant. Sure. And we should just look at it and pick it apart and see what makes sense. And because acute management as a team could be really helpful.
Sure.
That means anybody can help get to the point of oh, okay, all right, we've got this patient. It seems like it's this. Let's just follow an acute protocol. That might take time, but from 10 dentists in the office, it'd be nice to just have that.
Yeah.
And then they are funneled into a kind of, we need to manage you, definitively. But I think looking at that would be interesting.
Most definitely.
Cool.
All right.
I'm excited, man.